Let me introduce our first guest to the stage, the CEO of the California Medical Association, Dustin Corcoran. Let's give him a round of applause. Thanks, sir. I appreciate you doing this.
Thank you, DJ. Thanks for having me.
And the CMA has been very supportive in terms of trying to work with work with provider groups, physicians, to get them engaged, and I appreciate that, so thank you. I know you guys got a lot going on, and you're well regarded as being plugged into a lot of different conversations. We were chatting here just a moment ago, and you said the thing that you are most excited about is something you're doing in an innovative way, in an innovative space. Why don't you just give us the down low on what's getting you fired up these days?
Sure. Thanks for having me again, and good to be with all of you. I don't know about the well-regarded part for the audience's benefit that you've referenced to me, but I'll jump into this anyway. I was mentioning to DJ right before we walked up here a couple of the projects that we're working on and what makes me excited for the future. But underlying all of the new projects that we're working on and some of the innovative partnerships that are new and a bit unusual for CMA to be engaged in, the thing that's driving all of that is the simple fact that all of you know, and I'm sure share in common with me, that the healthcare system is not working right now. It's not working for patients, it's not working for providers, and if it's not working for either patients or providers, who is it working for? Healthcare costs too much, it's too difficult to access, and oftentimes the outcomes are not what we want them to be, and the incentives and motivations aren't what we want them to be. So we're really driving at ways that we can fundamentally change that and upend some of these programs without a massive upheaval as some have proposed in single payer or another type of system change like that. And to that core, we entered into a joint venture, a partnership with Blue Shield of California, kind of bringing together these warring factions and trying to get past the historical fights between health plans and providers and try and find if there's a different way that we can pay for and deliver health care in California. I'm heartened by it in part because, again, getting past this old us versus them mentality where we assume everything that the payers do is wrong and evil and they presume the same of us, but instead change how we, again, provide care in California. Core to this pilot program that we launched with them is changing the way physicians are paid and how they deliver care, and really trying to empower physicians to focus their time, their energy, and their efforts on those high acuity patients, those that need more hands-on treatment and care. Right now, a primary care provider spends anywhere between 30 and 50% of their time doing non-clinical work, and that's crazy. We've turned our physician workforce, the most highly trained, highly skilled portion of our workforce in healthcare, into glorified data entry clerks, chief financial officers, billing and coding experts, and that's insane. We need to get out of that and instead give that clinical time back to providers. And in giving them time back, not just add more 15-minute patient visits to their day, but allowing them to spend 45 minutes with a patient that may not have a social service network around them. Maybe they don't have family around them to help. Maybe they're living alone. And really spending 45 minutes with that high acuity patient to drill down on what's driving their healthcare needs and making sure that we can keep them out of the hospital and keep them at a lower expense rate by better engagement. I think that leads to better outcomes, greater satisfaction on the patient side. And our experimentation in this space shouldn't be limited to just what we're doing with Blue Shield, but we really should be looking across the entire healthcare delivery system. Medi-Cal in California is still largely a fee-for-service enterprise. Even though we have managed care, it's still largely a fee-for-service enterprise. How do we get Medi-Cal into this same value-based payment system that Blue Shield and CMA are exploring? And
correct me if I'm wrong, Sarah Summer will be joining your team to lead part of that, right?
Very excited to welcome Sarah to the CMA family. She'll be starting at the end of the month. Absolutely dynamic individual, and we're going to give her the keys to this vision and let her run with it in partnership with Jeff Baylett over on the Blue Shield side of this, and see if we can make some magic happen here. Yeah. But Sarah's an absolute all-star, and we're really excited to have her at CMA.
Yeah, good. How did you choose Blue Shield as a dance partner for this?
We didn't really choose them. I think we kind of just found each other as Paul Markovich was out articulating his view for the future, and I was doing some of the same things. We kind of just found our way to each other. CMA and Blue Shield do have a unique history. CMA did found and start Blue Shield of California.
Yeah.
I don't think Blue Shield likes to remember that part of our history, but we did, and we sold them for $1. So obviously we're great business minded people there at CMA. But that was a long, long time ago. But now we're coming back around. But I think it's in that shared vision for changing the way healthcare is paid for and delivered in California that brought us together.
So I think there's a lot of anticipation about health policy under this administration. I think, as Assemblymember Wood said earlier today, Governor Brown was not sort of motivated by healthcare. This governor is much more motivated by healthcare than the last. You, I understand, are close to him. What should we know about this governor's commitment to healthcare? I mean, he's got a long track record on it. It's extraordinarily complicated in terms of the political lift, not just the operations administration, but the political lift. Is this going to be a siege war over 4 or 8 years by this governor, or should we look for a blitz maybe with areas of opportunity, quick action where there are opportunities? How would you sort of enlighten us about what to expect from this governor?
Well, I don't want to speak certainly on the governor's behalf. It would be presumptuous and wrong and ill-informed on my part. But I missed much of your morning sessions, DJ, because I was sitting listening to Gavin Newsom give he didn't go 2 hours this time, but an hour and a half May revision press conference. I think left to his own druthers, he would still be going, maybe there at midnight, reciting random parts of health and safety code sections to justify some of his budget proposals. He is a detail-oriented person, particularly when he gets into healthcare policy. But you're right to identify this big shift from Jerry Brown to Gavin Newsom. When Jerry Brown got elected, when he was in his transition, the CMA leadership met with the new governor, as we do with all new governors during their transition period. Jerry Brown came to our offices with Diana Dooley, sat down, looked at the 7 physician elected leaders of CMA, myself, said, so I don't care about health care. What else would you like to talk about? It was an hour-long meeting. That was the opening. So you can imagine the look on the physician faces all flown to Sacramento. I don't know. We ended up spending most of our time talking about Prop 98 financing. He later came to our lobby day, 500 physicians in a room that particular afternoon, and spent an hour talking about prison reform. And just to make sure that we all knew that he knew where he was at, he came back up and talked about MICRA a bit, and then left. So that was Jerry Brown's view. Jerry Brown's view of healthcare, I think, is best surmised as for him it was a really large line item in the budget, and it was a line item to be managed. Gavin, in his May revision press conference today, talked a lot about the possibilities of healthcare and really framed it appropriately, I think, as an investment in California and an investment in its people. And I think that's a real opportunity for everybody in this room to work with this administration about envisioning a new future. Instead of fighting an administration to try and get any attention on healthcare, we're going to have an awful lot of that. With that comes opportunity and comes risk. But I think Gavin's articulated a really good vision for the possibilities of healthcare in California, universal health coverage, access and affordability for all Californians, and we're willing to partner with him and meet him to drive that path forward. I think it'll be, to your question about is it going to be an 8-year siege or is it going to be a quick strike, I think it's going to be a bit of both. I think the May revision certainly sets out some things that he's trying to get done right now within a year and have a longer-term conversation about cost, affordability, and accessibility in the system itself.
Yeah. How about Dr. Ghaly, a physician, now since middle of April at leading the department or the agency. What's CMA's view on the kind of talent and skill that Dr. Ghaly brings to healthcare and health policy in California?
Well, it's great to have a physician in that position, first and foremost, and Mark's a wonderful human being. And what I really like about what Mark's bringing to the table as secretary is his view on the most underserved parts of California. That public health perspective, the county-based healthcare systems, we haven't had that, certainly not at the state. I think it's been a top-down approach in many ways, and Mark's bringing that grassroots understanding of how you actually deal with care delivery on the ground for the most difficult to reach portions of our population. So that experience that he brings, I think, has been underheard and undervalued at the state level. There's a lot of advocates in the room that try and break through that with the governor's office and with the legislature. You now have somebody sitting at agency who has not only advocated for it, but has lived it and worked frontline care delivery, and that's really exciting.
Yeah. You know, the CMA is well regarded as both being bipartisan, neutral in terms of that division, and has a wide range of folks, some very progressive, some very conservative in terms of the membership. Yep. What do you make of what feels like a real progressive flashpoint in the health policy conversation? That might run into a legislative reality, but there's a lot of pent-up energy from nurses, from other advocacy organizations that want to make California the progressive beacon for the rest of the country. How do you sort of see some of that conversation, and what do you make of it maybe over the long term?
Sure. Well, from CMA's perspective, we do have a diverse membership. Our membership demographics, at least in terms of party registration, actually mirrors roughly the party demographics of California. So it's not as conservative as some people may think. But what's always impressed me about the physicians is they leave their partisanship at the door when they're talking about clinical care. They just fall into a provider state of mind, and the party labels are left behind pretty quickly in our board debates about where we're going to go. As it relates to what I will say are I think, slogan-based healthcare delivery system reform views of the world, that's not our focus, and that's not our jam. CMA is really focused on how do we get affordability and accessibility of healthcare realized for every Californian, make sure that every Californian, irrespective of immigration status, is covered. Healthcare is healthcare, and let's look at what's real, what's opportunistic for us to be able to actually do in this environment and get done. I'm not particularly interested in spending a whole lot of time talking about theoreticals and what ifs. We can let that play out in the 2020 presidential race. In the meantime, let's show what we can actually get done here in California for real.
Mm-hmm. Where does the single payer conversation fit into that world? Is it a post-2020 conversation, or is it more of a theoretical that doesn't have as much?
In my mind, it's absolutely a post-2020 conversation. California is not going to do single payer between now and 2020. It's not going to happen. I may get a phone call from my counterparts at another association. That's okay. But it's just not going to happen, and I'm not going to sit around and wait for that to happen. I don't think the rest of us should. We have a real opportunity, again, with the new governor to make significant advances. If those advancements then result in a different conversation, fine. If 2020 presidential election results in a different partner back in D.C. and we want to have a different conversation at that point, fine. But yeah. I don't think we should be in the business as Californians of waiting 2 years, or wasting 2 years in order to do that.
Yeah, one of the big policy topics that is in the weeds and is going to be decided or will begin certainly before 2020 is the next waiver negotiation for California. It's a big lift. The governor's still getting his team put together at the
still is, yes.
DHCS. How do you see CMA engaging in that waiver development conversation?
Yeah, well, I think Jennifer's done a great job over at DHCS, and I know that team is already working and getting the waiver process going and getting ready. Where I anticipate plugging in, and hopefully in a proactive way in this regard, is going back to what I talked about at the beginning. How can we fundamentally change how care is delivered and paid for in California, now with 1 out of every 3 Californians on Medi-Cal, 1 out of every 2 new childbirths on Medi-Cal? Medi-Cal has to go from a coverage-based entity, and I get it. After post-ACA, we needed to go all in on coverage. We needed to make sure that the plans were brought in, and we really focused on getting people coverage. Mm-hmm. Now we got to move past the coverage conversation and talk about Medi-Cal as a delivery system. When I talked about some of the innovative things we're doing with some private payers, you can't get there as a provider if in my estimation, at least 50% of your patient population has to be in that value-based payment structure for behavior really to change on the provider side and for patients to see a significant difference in the way that they're interacting with their care provider. That's hard to get there if you don't include Medi-Cal in that. So can we leverage the waiver process to accomplish some of those goals? And I think we can. I think we can be opportunistic with the waiver process to change fundamentally the way care is delivered and paid for in California.
Yeah, good. Dustin Corcoran, CEO of the California Medical Association. Thanks so very much for joining us.
Thank you, and I'm excited Elizabeth's following me. She's tremendous, so awesome. Thank you for having
me,
DJ.
Sir. Appreciate it. And next up, Elizabeth Mitchell, CEO and President of the Pacific Business Group on Health. Let's give her a round of applause. Hey.
I wanted to talk to Dustin.
Yeah, I know. I am like, on a list of two, I am a distant second. There's no question about that. Let me ask you first, what would you like to have said in response to Dustin about anything you heard?
What I think people underestimate is how much large employer purchasers have in common with physician organizations. We want the same things. We want health and good outcomes for our employees. It's their patients. So we are entirely aligned. What I was pleasantly surprised by, though, is our alignment on really the assessment of the current system. It is not working. Healthcare costs too much. There are too many errors. Quality is not where it should be. So there's a new level of readiness to act, at least on the part of my members, to actually do something about that. So there's a high level of frustration, but there's also a real readiness to partner.
So chart for folks, they may have heard the name Pacific Business Group on Health.
Yeah.
Who is that? Who are the members? How big is the organization? What does it generally do?
Sure, so I'm in my 4th week, but I've actually worked with Pacific Business Group on Health for years. And they've actually been around for 30 years. And they are really enabling large employers, and by large, I'm talking, Walmart, Boeing, Amazon, the big boys, to really help drive value and improved outcomes on behalf of their employees. So we do all sorts of things. We help them with purchasing, with measurement. How do you actually measure quality and value? We enable them to do things together. We support them through different programs, but they are really driving the change in the country right now. And again, they are willing and ready to do things that I haven't seen before.
So give us a sense of that, because let me just sort of like call out my cynical. I try to be optimistic about a lot of things, but one thing I'm not optimistic about is, employers getting willing to demand more value for their healthcare spend, because we all sort of think that at some point that's going to turn on, that light will turn on, and employers will sort of get motivated, and it always seems to lag. You're saying things are changing.
So I'm right there with you. I have been at this for 25 years. I've got sort of this unhealthy obsession with fixing the healthcare system. And I was skeptical myself, but I was in Washington with several of our members just last week. They are ready to engage in policy. There are policy proposals coming out of some of these Senate committees that will take on pricing, consolidation, antitrust, and they're willing to be engaged in a new way. But they're also doing things in the market. So we actually run a program for Centers of Excellence, and we have 2 or 3 major employers that are already using this. They are having their employees use these Centers of Excellence around the country. And we've just enlisted 3 new major Fortune 50 employers who want to do that. I've never seen that before. They're actually willing to go in and say, we believe that this is higher value, and what they're seeing is better outcomes, better experience, and they're actually saving money, so it's possible.
Yeah. People did say, and I think correctly, that a key difference maker in the Affordable Care Act negotiations and passage was that the business community came to the table in support of doing at least something.
At least something.
There's diversity on what, but the status quo was no longer acceptable. How do you feel like? Will the work that happens in the ERISA space, you talk about in the market space, will the work that happens in the self-insured space, how will that leach out into the rest of the, say, group market, the small group market? How will it leach out into Medi-Cal and Medicare? it's such a protected space where employers can do a number of things, but will the benefits of what employers do in that space, how will that be felt in other lines of business, do you think?
Well, I think the aim is certainly to have it support the overall market. So as an example, our members are entirely committed to supporting primary care, advanced primary care with integrated behavioral health. They understand that that has not been adequately resourced, and they are committed to doing that in a multi-payer or all-payer way. So we're talking with CMMI, how can we support some of these new multi-payer models? That will not just benefit their employees, that could benefit really the whole market. They are absolutely committed to data sharing and transparency. That's not just for them, that is really to actually enable a functioning market. So they're obviously focused on the health and well-being of their employees, but they are also committed to creating a functioning market for everybody.
Yeah. So since it's just you, me, a couple of glasses of wine, and a couple of other friends like Tanya Dansky and others around the table, let me throw this idea at you and see what you think. The best way, somebody told me once, the best way to make a sick person healthy is to take the sickest among us in, say, the commercial space, a 64-year-old, 60-year-old, and put them into Medicare, because now the 64-year-old is the healthiest compared to 80-year-olds. And expanding Medicare from 65 down to 55 or 50 is a great way to take sick people out of the commercial space, thus lowering costs, and moving healthy people into Medicare, thus lowering costs. That would seem to erode some of the ability to make changes with your larger employers. When you all engage in this space, what do you think about this Medicare for all? What do you think about this expansion of Medicare or a Medicare buy-in? Is that something that gets employers excited or not so much?
Well, let's step back. Like, healthcare is not the employer's day job, right?
Yeah.
They didn't want to be fixing healthcare.
Yeah.
They have products to sell or ships to build or whatever it is they do. But healthcare is now the second largest spend after compensation. They can't ignore it. And honestly, I think they would have been thrilled for government to fix it, for the system to fix itself, for the health plans to fix it. They are at the table now because they have to be. Yeah. So I think, we saw a poll just last week with our members that 57% of people are indicating support for Medicare for all. Yeah. I don't expect that to hold. I think it is simply a reaction to the frustration that people are feeling. It's unaffordable, it's not patient-centric, we're not seeing the outcomes and the value. So I think they are willing to be at that table and have that conversation because this is impacting them as businesses. This is getting up to the C-suite for the first time because it hasn't been fixed. So I don't think they have a specific position on expansion of Medicare, but they are willing to be part of the solution.
Yeah, I think that's, not that they haven't been willing to be part of the solution, but it sounds like the willingness to be very broadly minded, open-minded is
absolutely
is a little different.
Yeah, and think the ACA for employers was largely just a compliance problem. They had their heads down in compliance for years. Now they're sort of picking their heads up and saying, well, things are actually worse. Yeah. And we really need to do something about it. So they are engaging.
So one of the big areas of focus of the Pacific Business Group on health relates to transparency and helping to empower consumer choices, either by employers or otherwise, to drive down costs. We were talking outside about what we all have taken for granted in healthcare, cost shift, and that now as others are starting to talk about commercial rates being 200 and 300, in many cases more, percent higher than Medicare, are employers coming to realize that they're writing the checks for a lot of this stuff?
Absolutely.
Are they they're gonna keep doing it forever, right?
Yeah.
I wonder when they're gonna, are they starting to mobilize around that specific percent of Medicare and ask, why don't you charge us, California, physicians and doctors, why don't you guys charge us the same you charge Medi-Cal or Medicare plans?
Those are active discussions right now. And I know everyone was engaged in the conference, but today there was an article in the New York Times and in Forbes that quantified this 200 to 300% of Medicare pricing for employers. Now this is sort of not a very well-kept secret. They've known this, but it hasn't been publicly available. I mean, if you were in their seat and you're trying to pay for value, partner with providers, I mean, you really start to question this. So there is a very high level of frustration around pricing, and I think actually some of this Center of Excellence work is in response to that. It's not like they're not willing to pay for high value care. They are paying more for these Centers of Excellence, but they're also getting better outcomes and better experience, and they're lowering their total cost of care. So they are willing to come to the table and have those conversations, but they're not just going to tolerate, this outrageous pricing.
Yeah. So what do you think this means for the political conversation? I mean, this is all tea leaves, but since it's just you and me and a bottle of wine, what do you think
Where's this wine?
Tell me about it, right? What does this mean for the employer engagement in 2020 as we, that will be a big year. The election will shape the health policy conversation for the next at least, 4 years. Where do you think, give us a prediction, where will employers be plugging into that conversation within the context of the election? Are they going to become more active in the election cycle? You think they'll be talking about this more?
First of all, I'm speaking on behalf of a membership organization, so you know how complicated that can be.
Yeah.
But as I said, they are willing to engage in policy conversations right now in a way that I've never seen. And actually, some U.S. senators are willing to consider things like tying pricing to Medicare rates. How do you get at surprise billing? Some of the consolidation issues. Those are being discussed right now in Senate committees, and that hasn't happened before. So I think there is going to be some robust dialogue around what needs to happen to actually create a functioning market so that they can do value-based purchasing, so they can actually pay providers effectively for the care they want. I understand these alternative payment models. We need to be paying for what we value. And that's on us. And then we need partners on the provider side to really help drive better outcomes for everybody.
So in 2 years, when you're back up here and you've been at the Pacific Business Group on health for a couple of years, what will you like to say then about the 2 years? What will you have done in the next 2 years, hopefully, where you can say, our organization on behalf of its members accomplished these things?
What a great question. Well, I will tell you, we are really focused on impact. We are actually looking to enable our members to purchase care that is higher quality and actually lower cost. We are seeing significant savings that some of our members are experiencing through higher quality care. Mm-hmm. So we know that can be done. We intend to scale it. We intend to make it viable in the market, and we will be doing that collectively. So I think you can see a measurable impact, that's my prediction, my hope, on quality and value.
Yeah, and what will you, 2 years from now, like to say about what has happened in the Newsom administration about California health policy?
Well,
this is recorded, by the way.
Yeah, great. I'm actually an ex-politician. I don't say that very often. So I really appreciate the opportunity of having an administration that is this engaged, this informed, this committed to making a difference. You have a moment here in California. I was actually working a lot in Washington over the last few years. And in the last year or two, I kind of decided that wasn't the place to be having an impact. I think California is. You have got all the stars aligned and readiness, leadership like CMA and others, and this administration that's committed to making a difference. I think it's really exciting.
So you wanted to have asked Dustin a question. I asked you to respond to what you heard. We'll have Sacramento Mayor Darrell Steinberg up here momentarily. What would you like to ask him as a former legislator, leader on mental health, and now executive of his community? What would you like to ask him when we bring Mayor Steinberg up on stage?
How can we partner? I really believe we have the same aims. And how can you leverage employers? I mean, we have employers spending literally billions of dollars a year on healthcare.
Yeah.
How can you help us achieve a system where that is getting the outcomes we all deserve?
Yeah. Elizabeth Mitchell, President and CEO of the Pacific Business Group on Health. Thank you very much.
Thank you.
Well done. And next up, Mayor of Sacramento, Darrell Steinberg. Let's welcome him up to the stage, sir.
How you
Appreciate
doing,
you being here.
DJ? Thank you for having me.
Yeah. So let me sort of start with how is it being a mayor versus working with the legislature or in the legislature? How's it compare?
That is a great question, one I get all of the time. I don't think I always had an expectation that this job was going to be challenging, but I thought that after being president of the Senate during the roughest years in modern California history, budget-wise, that being mayor of Sacramento would be maybe a little bit easier. And it turned out I was wrong, because service is service is service. And the way I would say it is that being pro tem was arguably a more powerful position statewide. Being mayor of a growing city is much more intensive and direct in terms of the connection with the people, because everybody puts their hopes, their fears, their joys, and sometimes their frustrations on their mayor. And unlike passing laws and bills, which is finite, this is not finite. You just continue to square the circle in terms of trying to make progress on growing your city and on, on dealing with some of the major challenges like homelessness. All said, I'm having a good time, great time, but
Good. The
ups and downs.
You've gotten some shout outs from this new governor quickly and early.
Yep.
Assignments from this new governor. Why don't you tell us first what Governor Newsom has you doing on his behalf?
I have a couple of different roles in life. I, of course, have this day job as mayor, and then I am the founder of the Steinberg Institute for improving the mental health system in California. I'm joined by our executive director, Maggie Merritt, who's sitting over here, and they spend, and I help spend many hours. We have 5 full-time people that are walking the halls of the Capitol, working not as a stakeholder with a handout for resources, but to be kind of the voice that says, what is it going to take to build a better mental health system? And then Governor Newsom asked me if I would co-chair his task force on homelessness, which I know is going to launch very, very soon. The governor, as a former mayor who has dealt with these issues directly, just as I am now dealing with, understands that it takes a state, city, county partnership to really address the problem. And I think it's reflected in his budget. The May revision came out today, $1 billion to address homelessness. But he also wants to put his policy shoulder to the wheel, and I intend, along with other leaders throughout California, to help him and to help the legislature make this the public health and public safety priority that it must be in California.
You know, your city has gotten a lot of accolades for doing the hard work on whole person care and helping move people who are in housing insecurity or homeless situation into both stable housing with mental health, behavioral health, and physical health benefits. How much, I mean, I sort of assume, I don't know if this is accurate, but your leadership on mental health that goes back a long time must have in some way influenced the success of that. I mean, maybe you won't take credit, but how has that been so successful? Why has it been different here in the city of Sacramento?
So I guess I would go back to 20 years ago when I introduced my first mental health bill as a young legislator, as freshman assembly member with a lot more hair and I think a mustache. That was the first bill I introduced was AB 34. We called it Integrated Systems for the Homeless, Integrated Services for the Homeless Mentally Ill. We had enough money to help 1,000 people in LA, Stanislaus, and Sacramento counties, and showed over the course of a year, and we expanded from an initial investment of $10 million to $55 million, that if we did intensive outreach to people out on the streets and provided intensive case management and wraparound services, we called it, whatever it takes to not have the money be siloed, but allow it to be used for their mental health needs, their housing needs, their substance abuse issues, whatever it takes, that we could actually demonstrate huge reductions in days of homelessness, incarceration, and psychiatric hospitalizations. 20 years later, the lessons of that experience inform everything that we do today. For there is nothing really new under the sun. We know what works. It is intensive outreach. It is only half true that some people don't want help. You hear that a lot. Those people tend to be the ones with the most serious illnesses or the most serious drug problems. We also find, though, that if we stick with it and if you build that relationship of trust with that individual who may be traumatized, sick, and wary of bad prior experiences dealing with the system, that 75 to 80% of them will actually come in and get the help that they need. Combine intensive outreach with that case management approach, low barrier triage shelter, which is the new but absolutely essential piece of this, because many people who are mentally ill and chronically homeless will not go from the streets to permanent housing right away. We need that 4, 5, 6 months of shelter intensive assessment so that we can figure out how to help people get to a longer term housing setting with the services they need. Permanent housing, number 4. Number 5 are mental health and substance abuse services. We have that with the Mental Health Services Act, generating $2.4 billion a year in California. And finally, permanent supportive housing. The voters just passed the $2 billion No Place Like Home Act on last year's ballot. We now have real resources to actually devote to creating more supply of affordable housing combined with the services that will help people recover. Now, are we going to cure homelessness? No. Do we have the ability to make it much better? Absolutely. And that's what we set out to do through the governor's task force and through an enhanced partnership between the state and the cities and counties of California.
It's a lot. It's a lot.
Just give us a week. That's all we ask.
You know, it's a unique role that you play in terms of civic and political leadership on the issue of mental health. It's increasingly maybe not in vogue. There are more people talking about it today than there were 20 years ago.
Oh my God, yes.
Yeah, but it's there's still a lot of people that don't, they're still figuring it out. Tell us about what you're doing at the Steinberg Institute, specifically what you've been doing in the last few years as you've just gotten your feet underneath you, and then what you plan to be doing over the next few years.
Well, first thing we did, I say to Maggie and the team, if we did nothing else but come up with the idea of bonding against a small amount of ongoing Prop 63 funding to create a $2 billion housing bond called No Place Like Home, if that's all we did and we went out of business, it probably was a worthy endeavor. But we're about much more than that. We're trying to do several things. One is to shift the emphasis of this broken mental health system from a fail-first system, what we call stage 4, if you want to make an analogy to cancer. We have a stage 4 system, to a stage 1 or 2 system with a much greater emphasis on prevention and early intervention, college-based mental health services, early psychosis identification and intervention for teenagers, trauma-based mental health services and care for young kids who are exposed to violence and other traumatic events in life. I'm good.
Okay.
Actually, every other word that I say is meaningful, so the other word really it's okay. This actually works out better for me. We are working to change the paradigm of the system. The other thing we're working on is the recognition that one of the reasons why the system is broken is because there's no easy entry to access services. Here's one example, and it's wrong. In the county mental health system, if you are considered to be mild or moderate and you're of lower income, you can get help through Medi-Cal managed care. If you are serious and persistent, who's making these subjective judgments, by the way? If you're serious and persistent, you're not eligible for Medi-Cal managed care. You're only eligible for Prop 63 and realignment funding. We have multiple systems within the public mental health system itself. And then you talk about private pay and the aspiration for genuine parity, which doesn't really exist, the workforce shortage, which is very real, and the continuing stigma, which you're right, DJ, we have made significant strides over the course of 20 years. More people are talking about this, working on it, people are telling their stories, but it's still a fact that if your loved one suffers a heart attack and is rushed to a hospital, I guarantee you there will be a bed available for them. If your loved one is suffering through a psychiatric crisis and you call 911, the only recourse are the police, by the way, and they'll end up in an overstressed emergency room and likely sit on a gurney or in a cot if they have a bed in a hallway for a long time. I guarantee you that if a coworker breaks an arm and is out of work, they'll come back to work, and as a matter of honor, everyone will sign their cast. Your coworker misses work for 2 weeks or 30 days because they're living with major depression or bipolar illness. They will come back to work, and more likely than not, they'll never talk about it. We got a long way to go here, and so our work at the Institute, we have very mild aspirations here. We want to work with all of the stakeholders of the state, this new governor, the legislature, and we want to remake the mental health system in California to make it more functional, more prevention-based, easier to access, more humane, and to help more people. Like cancer, where 25 years ago, not only did we not talk about it, many cancers were a ready death sentence. Now that world has changed because we paid attention research-wise, care-wise. We intend to do the same thing with illnesses of the brain. And I believe we can do it because more people are talking about it, and there is a silent constituency out there because everybody deals with this. Every family knows someone. We bring it out of the shadows, we make it a political issue in a positive way, and we'll make great progress.
So, one of the lingering issues in the Medi-Cal space, where a lot of mental health activity exists, is the separation of the head from the rest of the body.
That's right.
And there's a procurement on the horizon where DHCS, where the state of California has an opportunity to reshape, at least to some degree, recognizing we're not getting, the waiver discussion will be ongoing, and there's an antagonistic federal administration and all of that stuff. But to what degree should the next procurement or the next rounds of conversation facilitate an even tighter integration of behavioral health and physical health financing and a tighter integration of behavioral health and physical health delivery?
There is no question that our aspiration must be to integrate physical and brain health in a more profound way, both in terms of funding, incentives, and actual practice of medicine. There's no question about it. And the system is replete with signals and messages that do just the opposite. When Medi-Cal requires somebody who comes on in to see a doctor because their stomach something is wrong with their stomach, and the attentive primary care physician recognizes that there might be a psychological component to the problem, their only option is to send that person home and have them make an appointment with the psychologist or psychiatrist a month later, because you can't bill for both the stomach problem and the psychological problem the same day. Well, that's really client-friendly, isn't it? That's one example among many. We must integrate, but there is a bit of a catch-22 that I think we need to acknowledge, because back when I was the legislative leader again, as in part policy-driven, in part budget-driven, we eliminated the Department of Mental Health and folded mental health into the healthcare agency and the Department of Healthcare Services. And I will tell you that that, in my view, was not a success. It was not a success because mental health became a complete afterthought within what was primarily a Medi-Cal implementation agency. So it's one thing and right to talk in theory and in practice about integrating physical and mental health, but then you better pay as a system or as a department equal attention to the mental health piece as you do the physical health piece. Otherwise, you'll have a great theory, but in practice, mental health will be left behind.
Yeah.
That's a cautionary tale about the rightful goal of integrating physical and mental health.
Yeah. It's a super important point in terms of that integration, that mental health often gets shortchanged, becomes a junior partner in the agency rather than an elevated and equal.
If that.
Yeah. So let me ask, Elizabeth Mitchell from the Pacific Business Group on Health wanted to ask you, how can they partner with you to transform healthcare? What would you like to say to her?
Well, obviously, so much of our healthcare system, including our mental health care system, involves some form of private insurance, whether it's managed care in the Medi-Cal realm or whether it's private pay. And neither system, frankly, places much of an emphasis on prevention and early intervention. It doesn't reward it. It doesn't reward approaches like whole person care, although the healthcare systems are stepping up and have stepped up in a major way in our county, in our city, and in other counties throughout the state to participate in these new and innovative approaches. But I would say get into the mental health debate in California in a big way. Don't look at it just as a responsibility or a burden, but look at it as an opportunity. Look at it as a humane opportunity, but also look at it as a cost savings opportunity, because you are paying the piper. We all are, for having a stage 4 system of mental health care instead of something that really helps people and makes them more productive and less in life and less of a burden to the very systems that are already overwrought and overtaxed.
Last question. We also had Dustin Corcoran, CEO of the California Medical Association, up here, said among the various things that he's watching, he's seeing, that he's working on, and innovation with Blue Shield of California around transforming the value-based payment system is the thing that excites him most. Is there a role for the City of Sacramento or the Steinberg Institute to engage in that in terms of value-based payment?
Well, I talked to Dustin quite a bit, and I know I'm going to be speaking at the CMA's annual conference where they're highlighting these issues of mental health. Absolutely. I think the fact that the state of reform has put together such a diverse set of panelists and speakers speaks to the opportunity here. I am not a believer that government can do it all. I mean, what is the Mental Health Services Act? It's a lot of money. It's also a catalyst. That's what it is. But it's only in combination with the rest of the system that we're actually going to answer the only question that matters. If I have a loved one in crisis, or if I'm in crisis, can I get compassionate, effective help in a timely way without making my already difficult situation worse? That requires the counties, the cities, the state, the departments, these disparate and large resources, together with the providers and the health insurance companies, to be together to collapse as many of the funding streams as we can, to provide the right incentives, to treat the things that are going to actually help people make people better sooner, and to do something that is a source of great pride to all of us, because we ended the stigma, not just of mental illness, but the stigma of a broken mental health system. It doesn't have to be that way.
Darrell Steinberg, Mayor of the City of Sacramento, thank you, sir, very much for being here. Let's give him a round of applause.